public health, and not just in law.
Hi everyone, I'm Dr. Faisel Syed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel Friends, where we believe access to primary care is a right, not a privilege. Today, we're talking to Dr. Regina Druz, ChenMed's National Director of Cardiology, about the heartbeat of primary care. Let's dive right in. Hi there, Dr. Dan.
Hey, Faisel.
Good to see you, and Dr. Druz, welcome.
Thank you. Hi, Faisel. Hi, Dan. Is it okay? We're going to be on a first name basis?
Yes.
Yes. So I'm Regina, in case, that way you don't have to figure out Druz, you can just say Regina.
Okay. Well, it's very, very nice to meet you, and thank you so much for coming onto the show.
Thank you for having me.
We have this series with our specialists in our primary care model, in our primary care delivery model. So we have this series we're running, like the role of specialists in primary care. And Dr. Dan has a wonderful name for this episode, the heartbeat of primary care.
Oh, goodness. Okay, the heartbeat of primary care. I love it. Very catchy.
Yes. And so before we get into talking about your role at ChenMed and what you've been doing for our primary care doctors and the care teams, we'd love to hear your story. We'd love to hear about where you went to school, where you trained, and your path to coming here to ChenMed to do what you're doing at ChenMed.
So CV and fast forward, right? Well, I am from New York. I came to New York in late 80s. I was actually one of those people who left the socialist country to experience the free world, and ended up there, went to medical school, which was fantastic. Went to Cornell and trained at New York Presbyterian Hospital, had a great time. And somewhere, in that journey, I was rounding in the ICU, and our chief medical resident came and he said, Regina, what are you really going to do with yourself? And I said, I don't know, maybe I'm just going to go into rheumatology or endocrinology. And he said, no, you know exactly where you need to go. You need to go into cardiology. And that sealed my fate. And I became a cardiologist. I stayed on at New York Presbyterian, finished my fellowship, and then went on to work at several institutions. I mostly focused on cardiac imaging, preventive cardiology, clinical cardiology, did some academic research. And finally, you asked specifically, how did that pass, found itself to ChenMed's door. I ended up working as a chief of cardiology at a community hospital that was part of a contract between my parent healthcare system and that institution. And that was an experience that I will never forget. I thought myself a very seasoned cardiologist by that time. And that was truly an eye-opening experience and probably a formative experience. And to kind of spare you the longer story, I ended up saying to myself, it's not possible that healthcare can run so badly. We have to do something different. And I went on to do an MBA and finished it in May, and got a call from ChenMed in July. and I'm here.
Wow. We are so grateful to have you here. And especially with your experience. I mean, you practiced cardiology, you were the chief medical officer for a hospital.
Oh, no, chief of cardiology and chair of the cardiovascular service line, not the CMO.
When you were there in that capacity, I mean, obviously the payment is largely based in the fee-for-service. So the incentive is there, to really react to the illness rather than wellness. How did you make the transition from this reactive sort of way of approaching, reacting towards cardiovascular disease and illness, to over here where we're focused on wellness and how we use non-physician clinicians to help us with improving health outcomes with cardiology?
So, Faisal, that's a great question, and I think maybe to answer it, I'll step back a little bit, right? Because not in the most proximal kind of end, before ChenMed, but at the beginning. When I was chief of cardiology, the population that we worked with was a very challenging patient population. We were basically serving the second largest Medicaid population in the entire New York State. And our hospital, even though it was a community hospital, had very limited tertiary services. It was surrounded by larger institutions, sort of their community outpost, if you will, whose interest was only in trying to get our patients in so that, as you said, they could max out on fee-for-service cardiac endeavors, right? Whether patients needed a cardiac catheterization, needed a pacemaker defibrillator, they had very low threshold for putting one in. And what they didn't care about is who these patients were. And a lot of these patients had very limited means. They couldn't really have access to resources that perhaps other cardiac patients have. They had not enough income to travel around to get their devices checked or things of that nature. Sometimes some of them were so poor, they had nothing to eat. And so they would come in with these electrolyte abnormalities that would set off their cardiac devices, and those devices would shock them, and they wouldn't understand why. So it was such a brutal situation. And this hospital was essentially the only medical institution in a fairly populated area. The area had a lot of immigrants from South America and Central America and all over. New York is very diverse. The hospital was in Queens. Queens is the most diverse borough of New York City. And that hospital was sort of the only survivor because another institution nearby essentially went bankrupt and they had to close. And so they would receive the money from the state and they would rebuild their emergency room. We helped them to structure cardiac services. But then I saw some of that money going to things that I just couldn't comprehend. For example, they would get a specific expensive radiotherapy for prostate cancer, but majority of their population were diabetics with heart failure. So they wouldn't really be helped by this. And the simple things, such as, for example, helping these patients get access to fresh food or help them to come to us and see us in clinic, give them some transportation, or potentially do something in terms of medications to lower the cost. And they actually started making some progress in that area. Those things were still very difficult to come by. And I thought to myself, I'm probably not the only person seeing it. There are many senior people above me, the chief medical officer is the CEO of a hospital, and I spoke with him regularly. All of us clinicians, we saw this. So we improvised as much as we could. We had a clinical pharmacist round with us. Our fellows, we didn't have fellows, but we had residents. We had fantastic family medicine, internal medicine residents that were super helpful, emergency room physicians that were very dedicated. But yet the entire system, it was pretty much rigged against the patient and a physician. And unless you were willing to play along, there was no way out. And if the tertiary institutions, including my parent institution, could not squeeze the procedure out of a patient, they really wouldn't be that inclined to transfer them over. It was just such a sad situation, and it was morally wrong, in my opinion. I didn't go into medicine to see people treated like that. We're a country where we believe a lot in the rights of the individuals. Maybe healthcare is a basic right, maybe it isn't. I'm not, somebody who's equipped to have this ethical discussion. But I think the basic care and compassion in that system was gone. And that was just not a good experience, but certainly made me learn quite a bit.
That's the paradox, despite all this progress, all the innovation, with how medicine responds to cardiovascular disease over the last, several decades, the outcomes for the patients, it varies. and varies, but based on some of the things that you just mentioned over here. I mean, their ability to afford the basics. That if a patient can't eat well, and their electrolytes are out of whack, and I mean, I never even thought about that, Doctor. I'm thinking when she was mentioning that, how many of these defibrillators were going off